Hello, my name is Margaret Sherratt. I'm a registered nurse, IBCLC. I've worked for 38 years in maternal child nursing in the hospital environment. I'm enjoying the opportunity to learn and grow as a Breastfeeding Committee of Canada BFI Coach Mentor. This presentation is about skin-to-skin care and supportive safe practices. The goals of today's presentation are to explore elements of safe care provision while supporting skin-to-skin and explore some of the concepts such as sudden unexpected postnatal collapse, infant falls, and safe sleep practices. Just a review of step 4 in the BFI indicators, we are encouraged to facilitate immediate and uninterrupted skin-to-skin contact at birth. We are to support mothers and birthing parents to respond to the infant cues to initiate breastfeeding as soon as possible after birth. In the new indicators, there's a built-in 5-minute kind of period that recognizes that some of these infants, or sometimes the birthing parent, needs that 5-minute interval to recover, or some type of supportive measures have to happen. So recognizing that 5-minute interval, and then once things are stable, that baby is up skin to skin, encouraging skin to skin for at least the first hour of life or completion of the first feed. The skin-to-skin principles also encourages us to support the teaching of the safety elements of skin-to-skin, and the settings include the operating room, now in the newest document extending into NICU, and also during painful procedures for infants. So HiRock is the company that often insures healthcare institutions, and of course a big component of their work is mitigating risk. So in most healthcare institutions, there is a risk management department. So their definition, HiRock's definition of risk management, is identifying, analyzing, and eliminating or mitigating risks that threaten an organization and the achievements of its objectives. So we have the risk management lens, and any kind of movement in healthcare is based on quality improvement. And of course, Baby Friendly Initiative, the impetus is improved to the quality of care that we provide. So we have the risk management lens and we have the quality improvement lens. And as these blend together, ultimate outcomes is improved patient safety. So I'm going to kind of review quickly the 4 categories of risk response using the principle of skin to skin and preventing the parents falling asleep. So we could use the first category of avoid. An example would be in this institution with skin to skin, we're not going to promote it because we don't want any chance of the parent falling asleep holding the baby. The next one would be accept, and just accept that this is an inevitable consequence of supporting skin to skin. So we're just going to kind of keep our fingers crossed. The next one would be share, and this is basically helping to allocate risk to others. So basically the principle, an example would be with new parents, I'm going to provide education and I'm going to have them sign a consent that the education was provided and that they're aware that falling asleep is a risk. The final one is control, and I think you can agree that this tends to be the principle that we follow in many decisions in healthcare. And so an example of control principles is building policy and procedure, is educating about those policies and procedures so that the staff is well equipped with sound practices, sound education to then support their clientele and educate their clientele using those principles and safety mechanisms. Weber reminds us, if there is no specific plan in place, the decision to implement skin-to-skin care and to do it safely will likely be made by the nurse's personal preference and the amount of risk that she or he is comfortable to assume. Tyrea, in their 2020 study, polled 95 hospitals in Pennsylvania. 64 actually agreed to participate in the study. So part of their their polling was they reached out to hospital staff about safety elements being the goal. So 50% of the staff reported that they actually had received no formal education on safe sleep practices. And another 20% stated that even though there was policies in place that supported skin to skin, that they actually had received no formal education on these policies and how to support them. I'm now going to kind of look a little bit deeper into some of the research about sudden unexpected postnatal collapse. So the definition is when a previously vigorous, spontaneously breathing infant who had a 5-minute APGAR of 8 or more unexpectedly becomes apneic, often requiring full resuscitation. Weber, in her review, has looked at some of the data and states the incidence is 2.6 per 100,000 to 133 per 100,000. She believes the large variation in data is because there's really no consistent definition about this phenomenon amongst different countries. And she also states that she believes there's an underreporting if there's good outcomes. Further research by Herlenos and Kroon looks at when these events are happening. 1/3 is occurring in the first 2 hours of life, 1/3 is between 2 and 24 hours of life, and another third is in that 1 to 7 days of life. To do a deeper dive in some of the research, in Bartik in 2020, her study says between 2014 and 2016 in the United States, 40% of the incidents were occurring in the preterm population. And, assuming preterm population is 37 weeks and below, really want to challenge you to think of those babies that are on your floor, because there's a real movement that our near-term babies are part of our circle of care on postpartum units. So whether we actually have a heightened risk because of those often 36 weekers that are sitting on our postpartum units, where traditionally they would have been in special care units in those first early hours of life. Davanzo, in their study, alarming statistics, said with sudden unexpected postnatal collapse that 50% of these children do not survive and 50% have long-term neurological outcomes. And there is a real kind of movement probably in the last 10 years that with anoxic events that there's infant cooling for 3 days. So these would be the babies that would definitely be included in infant cooling procedures. Perjevac and Herlenos, in their 2013 review, did a retrospective case review of 26 cases to see if there was themes that were starting to emerge. And some of the dominant themes is 15 of the 26 cases occurred when mom was lying flat on her back holding the baby. 18 of the mothers were primates, first-time moms. 13 were unsupervised breastfeeding within the first 2 hours of life, and 3 parents reported that they were on cell phone devices holding the baby when the event occurred. The authors actually went on to explode the concept of cell phone use, and they reported in their study that there had been reports of parents on cell phones, social media, reporting up to sending 30 messages in that critical post-delivery golden hour, 1 to 2 hours after the baby was born. And they also kind of took this traffic information. So we certainly know that cell phones are banned in our cars to be in our hands with a theft big fine now. And so they reminded of some of the research that actually shaped that practice change, so that the visual manual interaction between social media networking and texting has been linked to a 23-fold increase in the risk of traffic accidents. So they really challenge us to think, is it plausible that this research on traffic incidents and texting is transferable to our children in those golden hours? One of the strategies that some institutions use to engage parents in those critical early hours is the Winstrom's 9 instinctive stages of neonatal behavior. And just Google that. It's her research where the babies have the 9 steps that they go through in those first 1 to 2 hours of life as they acquaint themselves with the parents and get ready to feed. And it's a way to engage parents. There's some beautiful visual posters out there that can be used in this practice piece, a way to parents to kind of watch what the educational poster is saying and watch as their baby kind of mirrors through those 9 steps to initiate infant feeding. So a inexpensive, easy way to engage parents in those critical early hours. So some of the external stressors that have been identified is positioning. So prone position has been identified. When the baby's up against mom or her partner's skin, with the baby kind of buried in, nose against breast tissue, and any kind of facial occlusion with blankets or clothing. We also know that there's a blunted arousal response linked with maternal medications such as narcotics and magnesium sulfate. And we certainly see an increase in pregnancy-induced hypertension, and one of the management meds for moms with more extreme cases to control symptoms is magnesium sulfate. So perhaps more commonly used than it was at one point in time. Infants requiring resuscitation, maternal obesity. One study defined maternal obesity as if moms have a BMI of over 25. So anyway, 25 in a lot of the literature is not obese, is overweight. So anyway, just how one study interprets and defines. PRIMIP, so first-time moms, of course, postnatal fatigue. We already talked about the distraction of cell phones with just in causing distracted parents, but also the visitors and how there's distraction with visitors. And I really would love to see if there was any research done in the last couple of years, because we know that visitors haven't been as much part of the equation with COVID as there's been such kind of decreased visiting that has been supported. Unsupervised early feeds, family left alone in the recovery period, side-lying positioning has been identified, co-bedding, and once again, parents holding baby while lying flat on their backs. So High Rock, once again, the insurance providers released a report in December of 2022 that really helped us to critically look at systems risk factors. So we would be amiss if we didn't look at maybe kind of what's happening in our environment that may create more risk. So it's obviously no surprise for anyone that the biggest risk factor identified in hospital environments and also community healthcare settings is the recruitment and retention of staff. So we know that with COVID, it really did ignite the fires of people that were probably close to retirement, of taking the leap and leaving and saying, moving on into their next stage and retiring. So what that has left is we've got this whole kind of bottom part that we're heavy on the recruitment and light on the retention. That's just the reality that's happened. So we've got a lot of younger grads that are graduating from nursing school and coming into a more specialty area. It's great news because they're often really enthusiastic. They're often ripe for change. They're really good with the research and things like that to kind of help to bring those practice changes. But with those practice changes and that eagerness, what's missing is sometimes the mentorship, because so many of those nurses that chose to leave were the mentors of the younger generation. So we have that actually gap that's been created just because of the reality of the workforce and COVID. So that is definitely a risk factor, because now as we've been pedaling fast, that that you have to continue to build the policy and procedures, you have to continue the education. And with COVID, that's presented with real barriers, even the physical face-to-face education and stuff. We've had to become very inventive to actually support those learning needs of our newer staff members. AWAN also encourages us. So AWAN is the Association of Women's Health, Obstetrics, and Neonatal Nurses, American organization. They have developed beautiful materials, beautiful practices, policies to actually support obstetrical nursing. And so Canada, we've actually been able to benefit from many of their research practices. So they actually suggest that to provide safe, adequate care, one postpartum nurse needs to care for 3 mom and baby dyads. But sometimes with the staffing shortages, or even how the staffing models are built, it's not always 1 to 3. Sometimes it's 1 to 4, sometimes it's 1 to 5. So when you have newer staff potentially that are even more stretched, that can create certainly systems issues that could potential to impact safety. So Ludington and Morgan have developed this nice little acronym, WRAP, and it's a good way for us to be able to rapidly assess skin-to-skin contact. So it was developed to support labor and delivery, postpartum, and NICU nurses with their rapid assessment and documentation. So RAP is respiratory effort, A is activity of the infant, P perfusion, color of the infant, and P is how is the infant positioned. And a lot of times the charting fields in hospitals have been built to reflect this. So AWAN has encouraged us to be in those first couple of hours in their standards to do continuous monitoring by qualified staff. And if there's any identified risk factors, then increase the frequency of assessments and really emphasize education on supporting the infant airway with the parents. So most institutions have built some charting fields to support skin-to-skin safety, because remember the old premise, if it isn't charted, it wasn't done. So as I was doing a deeper dive with this presentation, actually this study actually made my heart, it's like, oh no, it was a little disconcerting. So Duplessis, in her 2021 study, she did a study focusing her study on the impact of oxygen monitoring to enhance patient safety with skin to skin. So part of her review is she did a chart audit, and she used a hospital with 1,400 deliveries, so you assume she did 1,400 chart audits. And she looked at the compliance rate. So she said the overall compliance rate to the hospital standard for neonatal observation when babies were skin to skin was only seen in 1 out of 5 cases. She said the documentation part, she said 40% of the charts had no documentation of any observation in that critical first hour of life. The author goes on to state that the low rates of compliance, she feels, speaks to the busyness of that particular obstetrical unit. So just kind of an aside note, remember her study was about using O2 sat devices to see about did this impact skin-to-skin safety and what the maternal feelings were about it. And she said the device was reassuring and did not impact maternal reports of bonding. So at least a good outcome in her study. But the other data was very alarming, because remember, if we didn't chart it legally, it wasn't done. So I want to thank Breastfeeding Buddies. It's a peer support organization that's a very well established peer support organization in KW region, Kitchener-Waterloo in Ontario, and they've done a really great job with their peer support. Their AVs, their visuals are top-notch on their social media platforms, and this is one of their ones that they just released recently, supporting safe skin-to-skin principles. So just to kind of the visual reminder, it reminds us that the baby's head should be on the chest, just below mom's chin, and that is when she reaches down, kind of she should be able to kiss the top of the baby's head. We kind of use the acronym visible and kissable, just like the baby wearing. Messaging from Health Canada. Baby's head is turned slightly to the, or slightly, a lot to the side, sorry. The chin is pointed up a little. The nose and mouth are not covered. The shoulders are flat against the chest. Those little legs are flexed. We know that's a natural newborn reflex. It's cute, but it's also protective because it just lifts the baby slightly off of the body to provide a little airway safety. And what you don't see in the poster is in the social media post just above, there was a comment reminding that once the baby's positioned safely, skin to skin is just covered lightly with one blanket. And tips for who's the mom or the partner who's holding the baby is that when the mom is sitting up, that she should be slightly leaning back and not lying flat, and avoid the distractors, right? We've already talked about the cell phones and things like that, so try to minimize those distractions. This is two more kind of examples of some of the posters that reinforce teaching for new families, and an example from La Leche League International about their skin-to-skin contact safety for babies and young children, and the transferable message from Health Canada from skin to skin, the visible and kissable, is actually transferable from their message to baby wearing. Okay, so their beautiful poster about safe baby wearing. So just a reminder that the BFI indicators really reminds us that the education is key to start in the prenatal period. So we know that postpartum women don't hear the messaging. Okay, I think there's one research that says mom has to hear the message 7 times before it imprints. Okay, because we know the brain isn't processing the same way. Various factors, hormonal, chemical, and overwhelming fatigue in the postpartum period. So it's key that information starts in the prenatal period. So information such as skin to skin, the importance of skin to skin, why we promote skin to skin, and the safety elements are key. YouTube is a beautiful little device for some of that information. There's some really good solid videos posted by reputable organizations, and this is just an example from CHIO, one of the hospitals in for kids near Ottawa, and an example of their video that they posted about the importance of managing pain in painful procedures for infants, encouraging skin to skin as one of those treatment modalities. And just a reminder that when we support education for anyone, that tell me and I will forget, show me and I may remember, and involve me and I actually will understand. So just wanted to chat about some of the safety devices that are out there that may enhance the safety elements of skin-to-skin care. And one of those is the Joey Band. The Joey Band was developed by a mom in Toronto from an occurrence in her life where actually her 10-day-old baby rolled off of her. So from her personal experience, she went on to enhance safety with the development of the Joey Band. And the Joey Band is basically a long piece of material with a whole lot of Velcro on 2 ends so that you can snug the baby up and then secure it with the Joey band. Joey bands are often used in NICU sites, sites. You'll see them used in the ORs. It's a good way to kind of position and keep the baby nice and snug on those skinny OR tables. We've used them for our blood sugar protocol, where we want to really encourage prolonged skin to skin to keep the baby nice and warm, and so they're not using up all those glucose stores, so that we've got optimal blood sugars along with feeding, so we can move the babies off the protocols as quickly as possible with solid blood sugar results. So Joey Band, nice little device. Another one we mentioned earlier was the O2 SAT. So in healthcare, we're always cognizant of our spending, and there is a cost to these monitors, but when you think about, we're using them all in our cardiac screening now at our 24-hour, when we're checking the O2 SATs to measure, if there's any potential cardiac abnormalities with that 24-hour testing. So, technically, if we used it in those early hours, we could just put it back on that nice little plastic backing that the tape comes with and keep it on the baby's crib, so that we have that device for the 24-hour testing. So some centers will keep babies with O2 SAT monitors in those first couple of hours in that critical period, and of course they're used all the time in NICU. Like most of those babies in NICU are on O2 SAT monitors continuously, and then as they graduate, kind of getting ready, kind of closer to discharge, they're often being held a whole lot more. Moms are establishing feeds, moving up feeds, and moms are tucked behind curtains, sometimes in NIU settings for extended periods of time when they're holding their babies. So it's another kind of way to assure safety, because obviously if they're tucked behind a curtain, your eyes aren't on the baby, but your ears are on the baby if they're on a O2 SAT monitor. Another, inexpensive device is the hospital gown. So Kathy, thank you for teaching us about this. So the hospital gown, mom can put it on backwards. They kind of bring it up around their waist, they tie it, and it forms that nice little pocket so you can tuck the baby in. So either partner can be holding the baby, and the baby's nice and secure because of that little pocket and that little kind of tightness that's been created with the hospital gown. And I would be amiss if I didn't remind us about safe staffing, that in our perfect world, we want the one nurse to the one nurse to 3 mother-baby dyads. So skin to skin in the OR, and it is kind of a paradigm change where, many centers started with skin to skin for vaginal deliveries, and as they grew their confidence and capacity, then they moved on to skin in the OR. And it's probably in the last 5 years or so, it's been more of a practice change, more of a paradigm change. So some of our education with skin to skin practices have been beautifully supported by the ORNAC standards for skin to skin in the OR. So ORNAC is the OR Nurses Association, and they've developed some beautiful standards that we can access, documents to support the practice of skin to skin in the OR. Probably the biggest factor too, beyond practice pieces, building policy, education, is that one extra staff member. So that one extra staff member in the OR to be responsible for the baby. So that staff member for eyes on the baby, and through that transition period when the baby's up skin to skin on the OR table. And of course for the safety elements, it's the eyes, but the hands for the safety elements of transfers. And for the emotional part of it too, because that extra staff member is often reminding parents, encouraging parents, supporting parents in those key early moments, early minutes after the arrival of their newest member of their family. And kind of recognizing that sometimes the reality of our staffing model is that sometimes we don't have that extra staff just because of the way life works. And so that often hospitals are actually, especially for elective sections, building that staffing element into their mix to encourage the safety part of skin to skin in the OR. Skin to skin in the OR also reminded that we have the potential to result in women requiring less analgesic or analoxic medications during and after cesarean births. These drugs can cause sedation, decrease women's memory of childbirth, increase incidence of respiratory depression, and increase the odds of having a challenging time with breastfeeding. So if Canada says basically about 25% of women have C-sections, the data is really clear that women that have C-sections often have bigger challenges with breastfeeding. So anything we can do to kind of help to even out the playing field is so key. So the practice of encouraging skin to skin in those early moments, hours, minutes is so key. And also to remember that we have a partner in the OR. So often the the other parent is in the OR accompanying the mother. So if for whatever reason she's unstable, then we can always tuck the baby up and support skin to skin safety with the partner in the OR. And just in a side note, one of the big kind of sells with skin to skin in the OR is often when you witness the decreased rigors for these moms, so those often awful shakes that moms get after they deliver a baby. So when they're holding the baby skin to skin, that is rapidly decrease, so that even the safety element of her not feeling like she's going to shake off the bed with those awful rigor shakes at the end is one more way that skin to skin enhances the safety. Duthie, in their 2020 review about infant slips and falls, really encourages us to reframe our thinking. The reality, the statistics say that the majority of falls, infant falls, happen at night. And when we look at women's sleep, they often only sleep 3.7 hours in 24 hours postpartum. So that is not a lot of sleep to function on. And remember, they're coming into this experience often exhausted. The peak of falls often are at 4 in the morning. And the other thing that Duthie really critically encourages us to think about is the concept of sleepiness. So normally when we lie down and we go to sleep, we often have that window of 5, 10, 15 minutes of we're contemplating life before our brain shuts down and we're able to fall into a deep sleep. Well, Duthie reminds us that when you're exhausted, you lie down to sleep. And you don't have that buffer of 5 or 10 minutes conscious feeling of, oh, I'm going to fall off to sleep now. So many of the principles that we're teaching parents are, if you're sleepy, then put your baby, over in the crib. Well, the reality is, with exhaustion, the feeling of sleepiness presents, but quickly, within 1 to 7 minutes, sleep follows. So encouraging us we need to maybe rethink some of that messaging based on the population. And anybody that works in obstetrics can attest to the fact that often fathers are really sleepy. The partners are really sleepy because what happens is the birthing parent has that beautiful adrenaline that actually kind of carries them through, gives them that little buffer for the first 24 hours of life. But then what happens is they crash. Their partner doesn't have the advantage of that hormonal rush to carry them through in that first 1 to 2 days. So as a result, often the partner is very sleepy, and it's in a lot of the statements about safe sleep and skin to skin, we're actually calling on that sleepy partner to be the eyes to kind of watch over the dyad. So really kind of critically thinking, it's like, maybe we need to rethink that. So Duthie once again encourages us to move away from the illusion that we can keep parents awake. We really need to look at safety measures that are grounded in science. So in some ways, I'm actually envious of the United Kingdom because they're very proactive in some of the safe sleep and principles. And one of those is using these sidecar items. So where it's that little crib that kind of tucks butt under the mattress so that as soon as the birthing parent starts to feel sleepy, the baby can be kind of slipped over into the sidecar. And it would be a beautiful thing if those were being marketed and more available in Canada. Doing kind of a search 3 or 4 years ago to look at whether these were even available in Canada came up very short. So anyway, it would be a beautiful thing because I do think this would enhance safe sleep practices, especially for moms that maybe are sedated with medications, our C-section moms. They would provide safer care, 100%. So this image on this slide, Public Health Agency of Canada, so they've done a lot of great development with the materials, a lot of great messaging to decrease the incidence of SIDS with safe sleep practices. So, the idea of the baby in the crib, not any blankets, not any extra materials around the baby, and of course that the baby is sleeping on their back. So 20 years, the incidents have decreased. So we can't dispute the research and the messaging. But I heard a coroner probably about 7 or 8 years ago speak, and his talk was about SIDS and some of his findings. So the coroner, Dr. Dirk Hewer, and he was in the Wellington County. I believe he's actually the head coroner in Ontario now, or one of the head coroners, and he really encouraged us to really critically think about the messaging about safe sleep is crib focused, which is great. That's where babies sleep, but those babies also sleep in other parts of the house, and we need to extend that messaging for parents for where that baby else is sleeping in other parts of the house. And the message has stuck to this day, obviously, when he really talked about the soft pillow couches. So that's what we're buying. Like, think about when you go shopping for these couches these days, is all these soft pillow top couches with these thick, thick pillows, right? So he believes that's probably one of the most riskiest environments now, is what's sitting in our living room and rec rooms, as when parents will lie down with their baby on their couches and quickly fall off to sleep, how the danger of entrapment is very real for families. And also that on these couches, of course, the safe sleep is about not in the beds, but the reality is on our couches and stuff, we still have our pillows, we still have our comforters and things like that. So we really need to really think our teaching isn't just about the crib in the room beside the parent, it's about the whole house. And just as an aside note, a lot, we're teaching the safe sleep principles and some of the harm reduction messages. But really think about, have you gone shopping for a mattress in the last 5 years? Because it's almost impossible to find a mattress to purchase now that isn't got that thick pillow top mattress. So I would think this is a heightened risk in the reality of harm reduction messaging. So we really need to kind of teach parents about that, okay? So in our practice, all of us, I don't think we can dispute that skin to skin is a game changer for our families. I truly believe it's probably the biggest paradigm change I've seen in my obstetrical career. I've seen it change practice. I've seen it empower parents, light up babies. An amazing, amazing paradigm change. But in our life, the constant in life is actually about change. Healthcare is always changing and advancing. There's new research, new technology, new devices, and new procedures, new products. We need to embrace the opportunities to improve the care for our new families. I challenge each of you to critically examine where you are providing care for your new families. The BFI principles improve the safety of care we deliver for our families. But what are your next steps to actually take this knowledge about skin to skin and then to enhance safe care while supporting the important practice of safe skin to skin? Really encourage you, be the change that you want to see within your healthcare arena.